to everyone. Thank you for giving me this opportunity to speak about chronic hypertension today. We're going to look at some factors that drive risks in pregnancy, and we'll focus on maternal mortality associated with hypertension and morbidity associated with hypertension. I'm a clinician. I'm a maternal fetal medicine doctor, and so I am not an epidemiologist, although I work with a great team of epidemiologists here at Rutgers. There we go. All right, I have no financial disclosures to report today. And here are my objectives. I'm going to provide an overview of chronic hypertension. We'll talk about associated risk factors, adverse pregnancy outcomes, and management for pregnancies complicated by chronic hypertension. We'll talk about the epidemiology of chronic hypertension and associated maternal mortality. And finally, we'll review the disparate maternal mortality rates associated with hypertension among Black and white people and review contributing factors. Hypertension is one of the most common medical disorders encountered in general medical practice. More than 100 million adults in the United States have hypertension, and approximately 10% of reproductive age women have hypertension. In pregnancy, we talk about chronic hypertension, and that's also known as pre-existing hypertension, and it's meant to distinguish hypertension that pre-existed pregnancy from the hypertensive disorders of pregnancy, like preeclampsia or gestational hypertension. The American College of Obstetricians and Gynecologists defines chronic hypertension as hypertension that is present before pregnancy or hypertension that is first recognized in the first 20 weeks of pregnancy. And that is chronic hypertension. It's further sort of categorized as mild hypertension versus severe range hypertension. And mild hypertension is a systolic blood pressure greater than or equal to 140 millimeters of mercury, or a diastolic blood pressure greater than 90, on two occasions, 4 hours apart. Severe range hypertension is defined as blood pressure greater than 160 over 110. In 2017, the American College of Cardiologists and the American Heart Association changed the definition of hypertension. And what they did is they lowered the blood pressure cutoffs to include people with blood pressures in the 130s over 80s, and now they labeled these people as stage 1 hypertension. The ACC and AHA changed the diagnostic criteria for hypertension in non-pregnant adults based on evidence that cardiovascular disease risk increases linearly with increasing blood pressure, even below the cutoff that we were using previously, that 140 over 90 cutoff. And one of the consequences of this change in blood pressure definition, hypertension definition, is more people in the United States have hypertension. And it's estimated that this change in the definition of hypertension increased the prevalence by nearly 5 million adults in the United States. This new definition also doubled the number of reproductive age women and other pregnant people in the United States with chronic hypertension. Here are two studies that looked at the impact of the new definition of hypertension. One came from NHANES data and included reproductive age women aged 20 to 44 from 2011 to 2014. And by ACOG's definition, 10.2% of pregnant people had chronic hypertension, but by the new ACC-AHA definition, the prevalence of chronic hypertension increased to 18.9%. Excuse me. In another study looking at patients in California from the Kaiser Permanente group, that it looked at reproductive age women aged 15 to 49 from 2009 to 2014. The rates of, or the prevalence, of chronic hypertension increased from 10.3% to 28.1%. The implications of this new definition for hypertension is not clear in pregnancy. The American College of Obstetricians and Gynecologists continues to use the definition that we were using before this change of 140 over 90, and that's what we're going to be using in this discussion of chronic hypertension risks. And it's still used in many epidemiologic studies of pregnancy. So let's take a look at the epidemiology of chronic hypertension in the United States. And we're going to start with a study published by my research mentor, Candy and Nanth. It was published in Hypertension in 2019, and it looked at the prevalence and trends of chronic hypertension in the United States from 1970 to 2010. What Dr. Nanth did in this study is he looked at national hospital discharge data that included all hospital admissions that resulted in childbirth, and it included deliveries from non-federal general and specialty short-stay hospitals. And data was representative of all hospital discharges in the 50 states and in Washington, D.C. And Dr. Nanth looked at the trends in chronic hypertension compared to normotensive women using ACOG's definition of hypertension, again, 140/90. In this study, which was massive, 151 million hospitalizations were included over the 4 decades, and the overall prevalence of chronic hypertension was 0.6%, with Black women having more than 2-fold higher rate of chronic hypertension compared to white women. In this study, they did an age period cohort analysis, and this is a really neat epidemiologic test or analysis, which looks at time-varying elements in epidemiology and see how these different elements contribute to the outcome of interest. And they focused in the age period cohort on these 3 factors: the age effects, the period effects, and the cohort effects. Age effects are impacted by advancing age at childbirth. Period effects are defined by the year of death. What we're talking about here are external factors that affect all age groups at the same time. We're talking about secular variation due to extraneous factors like medical therapies at the time of death and ascertainment of these outcomes. The cohort effects are defined by the year of birth. And here we're talking about the unique experiences of a group or cohort as they move across time. And this is characterized by cumulative exposures to social conditions. We're living through one right now, a pandemic. That's going to impact the cohort effect, for example. Lifestyle, of course, rates of obesity, behavioral factors like tobacco use. These all provide insight into the cohort effect that we can look at in this type of analysis. So this is the figure that was generated of looking at trends in chronic hypertension from 1970 to 2010 with the age, period, and cohort effects illustrated. So let's break it down a little bit and look a little bit more closely. We'll start here with the age effect. So on the x-axis, we see maternal age, and on the y-axis, we see the rate of chronic hypertension. The black line shows the overall rate of chronic hypertension, and we see a very strong age effect for chronic hypertension. As women age, that rate of chronic hypertension increases. This age effect is also seen here in the red and blue lines, where we've stratified the analysis by race. The red line corresponds with the rate of chronic hypertension among Black women, and the blue line corresponds to the rate of chronic hypertension for white women. And we see here that there's a very strong age effect for both Black and white women, but there's a very big disparity where the risk and the rates of chronic hypertension is significantly higher at the same age for Black women compared to white women. So summarizing that, the rates increase with age of chronic hypertension and higher rates for Black compared to white women. Now let's take a look at the period effects. Again, this is the secular variations that are due to extraneous factors like medical therapies at the time of death. And on the x-axis, we have the period time scale. And on the y-axis, we have the rate ratio for chronic hypertension. Using a reference of 1970, we see a significant increase in the rate ratio of chronic hypertension during the study period. Again, this pattern was the same for overall people and Black and white women, but what we see was that prevalence increased, that rate ratio, increased for chronic hypertension more substantially in the blue line and for white women compared to the red line of Black women. So the period effects here illustrate that the the rate ratio for chronic hypertension increased during this 40-year period overall, but it increased even more substantially for white compared to Black women. Now let's take a look at the cohort effect here. This is characterized by cumulative exposures to social conditions. And actually, we don't see significant cohort effects here. So most of the effects that we see most pronounced were in the age effects and in the period effects. So to summarize this study, looking at trends at chronic hypertension over the last 40 years, we see a powerful maternal age effects. That as women age, the risk of chronic hypertension increases substantially. We saw substantial increases in the rates of chronic hypertension over the last 4 decades. And we saw a profound race disparity with widening race disparity by maternal age. And we also saw, I think somewhat surprisingly, that rates increased more so for white compared to Black women. Now let's look at the epidemiology of preeclampsia in the United States. This paper was published in the British Medical Journal in 2013. It used the hospital discharge data, again, that we used in the last study, and it followed all hospital discharges in the United States and Washington, D.C. From 1980 to 2010, and looked at trends in mild preeclampsia and preeclampsia with severe features. The study was also very big and included 121 million hospitalizations that resulted in childbirth. This is the age period cohort analysis looking at mild preeclampsia during the study period. We're going to focus on first on the left side, the age effects. Here we see a different distribution compared to the chronic hypertension charts we were looking at a little while ago. We see that the age effect is most pronounced at the extremes of ages for very young and very old women. At the very young and the very old sort of endpoints of care, that's when the risk of the rates of mild preeclampsia was highest. Looking on the far right at the period effects and using 2000 as the reference, we see a substantial reduction in rates of preeclampsia during this time period. Concurrently, while preeclampsia rates are decreasing, this looks at the sort of percentage of preeclampsia by mild and severe features. And we see the rates of preeclampsia with severe features have increased during this time period between 1980 and 2010. So looking at the epidemiology of preeclampsia, we see strong age effects, mostly at the extremes of aging, and the rates of severe preeclampsia appear to be increasing. So what's driving these trends? What are the factors that are leading to an increase in chronic hypertension in the United States and increases in preeclampsia with severe features? Well, let's take a moment and look at risk factors for chronic hypertension. If you look into chronic hypertension, these are just the classic risk factors: maternal age, obesity, race, family history, issues, compliance with diet, alcohol consumption, sedentary lifestyle. And we're going to dig a little deeper into the top 3 here: age, obesity, and race, and see how they contribute to trends in chronic hypertension in the United States. We know that women are deferring in childbirth for various reasons, and we're seeing older women who are pregnant. Right now in my practice, our oldest patient is 53 years old. These are some really compelling pictures that were published in New York Magazine in 2011. The title of this, the lead article was, "Is She Just Too Old for This? New Parents Over 50, Childrearing's Final Frontier." And there's a nice picture on the right here of a woman named Fiona Palin who's breastfeeding her daughter, and the woman is 49 years old. For this portion of the talk, I'm going to mostly be looking at vital statistics charts and figures to sort of look at the interplay of these various risk factors and how they're contributing to chronic hypertension. So we'll start here with birth rates, first birth rates by selected age of mother in the United States from 1970 to 2012. And this is stratified by maternal age, 35 to 39 and 40 to 44. And we see that the first birth rates for women in their late 30s increased substantially during this period from 1970 to 2012. But we also saw an impressive increase among first births for women in their early 40s. And that really started after 1980. This looks at the percentage of first births by age of mother in the United States. And I like this figure because you can see sort of based on stratified groups of ages, how over this 15-year period, there were changes in the rates of first births. So women under the age of 20 in the 2000s, they represented 23% of first births. And by 2014, the rates had decreased to 13%. For first births and for women in the early 20s, the rates were stable, around 28.7%. And we see that the rates have increased for women in above the age of 25 for the age of their first birth, increasing for women 25 to 29 from 24 to 27%. For women in their 30s, representing now 21% of all first births, and women over the age of 35, more than 9% of first births. This data is shown slightly differently here, mean age by birth order, and we see that the age of first birth has increased dramatically in the 2000s, and as with substantial births, or consecutive births, we see that the maternal age is just increasing. Now we'll talk a little bit about obesity trends in the United States. I think most of us have seen these trends in the US. In 1990, the prevalence of obesity, defined as a BMI over 30, for most states was less than 15%. Fast forward to 2010, now many states have a prevalence of obesity of more than 30%. And looking at obesity rates in 2020, where this is the most recent data available, we have many states where the prevalence of a BMI over 30 of class 1 obesity is greater than 40%. There's a relationship between age and obesity. We see as people age, they tend to have heavier. And if you just look at the group of women 40 and older, and they're among the heaviest that we see in this breakdown based on age, and the weights are increasing, or the prevalence of obesity is increasing between 2016 and 2019. We know that obesity and weight gain are major risk factors for hypertension. In a classic study in JAMA that was published in 2009, it was a prospective cohort study of more than 83,000 women who were reproductive age, 27 to 44 years old. And obese women had a hazard ratio for incident hypertension of 4.7 compared to women who had a normal body mass index. And in this population, 40% of new hypertension cases could be attributed to obesity or overweight status, it's just really remarkable. There's a relationship between obesity and race, one that requires further study. In looking at data from 2017 to 2018, the prevalence of obesity among adults in the United States who were non-Hispanic Black was 57%. Among Hispanic females, adults, 44%, and non-Hispanic white females, 40%. And this is shown slightly differently here. This is age-adjusted prevalence of hypertension among adults by sex and race. So I've highlighted the women here, and we see that among non-Hispanic white women, 39.9% had hypertension, according to this data from the National Health and Nutrition Examination Survey from 2015 to 2016. I'm sorry, that's non-Hispanic Blacks were almost 40% here. Black people in the United States have one of the highest rates of hypertension in the world. Black people have earlier onset of hypertension, have poor control, increased end organ damage, and more prevalent comorbid conditions compared to white Americans. So we've just looked at here, an exploration of factors such as maternal age, obesity, and race, and the interplay leading to increasing rates of chronic hypertension and likely contributing to the increasing rates of preeclampsia with severe features as well. And that leads us to a discussion about the risks, of chronic hypertension and why this is such a significant issue in pregnancy. Women who have chronic hypertension are a significant risk for adverse pregnancy outcomes, with more than fivefold increased risk for complications including acute kidney failure, pulmonary edema, superimposed preeclampsia, death, and stroke, compared to women who are normotensive or don't have chronic hypertension. Chronic hypertension is also significantly associated with abruption, which is premature placental separation before the delivery of a fetus. That results in adverse outcomes and postpartum hemorrhage, bleeding. And these are just a quick review from of some of the maternal risks associated with chronic hypertension. Neonatal risks are also significantly increased among women with chronic hypertension. Perinatal mortality, admission to the neonatal intensive care unit, and preterm delivery. Preterm delivery is so important. How babies do depend on when they are born, and chronic hypertension is significantly associated with an increased risk for preterm birth. It's also associated with higher risk for birth weights that are less than 2,500 grams and small for gestational age birth, reflecting impaired fetal growth. These risks, both for maternal and adverse pregnancy outcomes, increase based on the severity of hypertension, the presence of end organ damage, and superimposed preeclampsia. And although the relative risk of these complications are significantly increased, I do point out that the absolute risk for serious end organ damage is still low in the absence of severe preeclampsia and uncontrolled hypertension. We've learned that chronic hypertension is associated with cardiovascular disease, but we also know that preeclampsia is associated with an increased risk for future cardiovascular disease. Pregnancy is a window into the future. In a systematic review and meta-analysis that included 22 studies with over 6.4 million women and more than 250,000 women with preeclampsia, the risk for future cardiovascular disease was substantially increased among women who had preeclampsia. The risk of future heart failure, the risk of coronary heart disease and cardiovascular disease death and stroke were all substantially increased in the future, again, for women with preeclampsia in pregnancy. And in sensitivity analysis that controlled for age and BMI, preeclampsia was still associated with increased risk for these complications in the future. So what about trends in hypertension-associated maternal mortality? I think this is one of the reasons that so many people joined today to hear about some of our results in a new study we published in this past year in 2021 in hypertension. This was called the Historical and Recent Changes in Maternal Mortality Due to Hypertensive Disorders in the United States. And we looked at 1979 to 2018. We included US mortality and live birth data. So we used death certificates to identify maternal deaths and birth certificates to ascertain live births as our comparator. And we looked at all maternal deaths during pregnancy and up to 42 days after delivery. And we used ICD-9 and ICD-10 codes to ascertain hypertensive associated deaths. And in this study, which was quite big, we had 155 million live births and 3,287 hypertension-associated deaths. And we evaluated trends in maternal mortality ratios per 100,000 live births. So here's the age period cohort figure looking at trends for preeclampsia, and we're looking overall, looking at all people who were in the study. On the left, we see the age effects, and we see a significant age effect for preeclampsia-associated maternal mortality ratios. On the right, indicated here, using 1980 as our reference year, we see a substantial reduction in the preeclampsia-associated mortality rate ratios during this 40-year time period, with a reduction, an annual reduction of 2.1% per year. So again, strong age effects for preeclampsia associated maternal mortality. And during this study period, there was a reduction in the preeclampsia-associated maternal mortality rate ratio during this time period. So we then took this analysis one step further and stratified by race. The green line corresponds with Black women. The blue lines correspond to white women. And looking on the left, we see the, again, strong age effects for preeclampsia, associated maternal mortality, where the risk of dying from preeclampsia increases significantly with age. And we see a real significant disparity between Black and white women here. Looking on the right at the period effects, we see that the the preeclampsia associated mortality rate ratio decreased for Black and white women during this 40-year study period, although the reduction was not quite as great for Black women. But we did see an annual decline of 1.7% for white women and 1.8% for Black women in the preeclampsia associated mortality rate ratio during the study period. Now let's look at chronic hypertension. And what we see here, this is overall, including all people included in the study. And we see, again, a very strong age effect on the left for chronic hypertension associated maternal mortality ratios. In contrast, on the right, looking at the period effects, though, and using 1980 as our reference year, we see a substantial increase in the chronic hypertension associated mortality rate ratio during the study period. The annual increase in MMRs associated with chronic hypertension was 10% per year during the study period. And breaking this down by race, we see, again, similar trends with disparities between Black and white women. In the age effects on the left, you see strong age effects for Black and white women for chronic hypertension associated MMRs, although the risk's greater at the same age for Black women, again, compared to white women. And then on the far right, when we're looking at the period effects, we see a substantial increase in the chronic hypertension associated mortality rate ratio during the study period, and it was more significant for Black women, that increase compared to white women. And you'll notice I'm not focusing on cohort effects very much in these tables because they didn't play a significant role. So again, age effects were substantial here with the disparity between Black and white women. And then looking at the period effects, we see a substantial increase in the rate ratios for chronic hypertension associated mortality for Black and white women, with the biggest difference for Black women. So to summarize the trends in maternal mortality ratios associated with chronic hypertension and preeclampsia during this 40-year period from 1979 to 2018, we see a reduction in MMRs associated with preeclampsia during the study period. And during the same time, we see an increase in MMRs associated with chronic hypertension. So here in this table, we see the annual change overall and for Black and white women, and broken down by preeclampsia and chronic hypertension. And what we see here is that we're doing better with preeclampsia, and we are not doing as well with chronic hypertension. And in this figure, we see hypertension-related maternal mortality rates overall and among Black and white women. The red sort of lines indicate the mortality rates and 95% confidence interval for everyone. And then the green represents the mortality rates for Black women and blue for white women. And we see a significant disparity between hypertension-related maternal mortality rates that persisted during the study period, at least 3 to 4-fold higher rates of hypertension-associated maternal mortality for Black women compared to white women. And again, this was preserved during the study period. So in summary here, maternal age has a profound effect on hypertension and hypertension-associated maternal mortalities. During the study period, chronic hypertension rates increased substantially. But when we look more at hypertension-associated MMRs, what we see is there was a decline in MMRs associated with preeclampsia during the study period. We saw a substantial increase among those with chronic hypertension, and we saw a persistent 3 to 4-fold higher rates of MMRs associated with hypertension among Black women compared to white women. So let's put this all together. All right. So our data suggests we are better at managing preeclampsia and the hypertensive urgency that comes with preeclampsia. There is the Safe Motherhood Initiative, which is a hospital-based obstetric quality improvement program that's been widely used and implemented in the New York, New Jersey area. It provides resources for hospitals looking to target leading causes of maternal death, and it's focused on sepsis, obstetric hemorrhage, venous thromboembolism, and severe hypertension. This is one example of how we have sort of standardized our approach to management of hypertension and pregnancy associated with preeclampsia. And there's lots of resources available for clinicians and hospitals, to sort of, again, to standardize the approach to these problems and to prevent morbidity and mortality. This is just one example I pulled off the Safe Motherhood Initiative website. It really defines what is severe hypertension and what is hypertensive emergency. And it gives very clear guidance for when we should be repeating blood pressures and when we should be contacting physicians and when we should be treating these pressures. And it sets standards for timely evaluation and management, and also gives us a quality metric so that we can follow to see how effectively we are at managing preeclampsia with severe features when patients present and blood pressures are very, very high. The Safe Motherhood Initiative has given several algorithms for management of severe hypertension. Here's just one example with labetalol, but there are other management algorithms employing other antihypertensive medications, including hydralazine and nifedipine. And what this does is it forces us to be regimented and algorithmic in the management of preeclampsia with severe features when someone has high blood pressure, and gives us an approach that is standardized so that we can be more effective at, again, lowering the pressure safely and reducing the associated morbidity that comes with severe preeclampsia. And they also, again, the Safe Motherhood Initiative also provides various checklists. These are just two examples for the management of hypertensive emergency and eclampsia that have been used in New York and New Jersey, and have helped us be more effective at managing preeclampsia with severe features. So our data shows that we're better at managing preeclampsia, and we are probably reducing the associated maternal mortality ratios. And now I think what we need to do and what our data illustrates is we need to focus on chronic hypertension. We need to do better here. I see patients in the office as a maternal fetal medicine doctor. Majority of my consultations are perinatal for pregnant people who are already pregnant. And a minority of my consultations are for people who are not pregnant, but are considering pregnancy. And what we need is more people who have hypertension to come to my office and to MFM offices to have preconception counseling, to talk about the risks associated with pregnancy and to make changes before a pregnancy starts. If people come to us and we talk about nutritional interventions and exercise, we can reduce the body mass index and obesity and blood pressure, we're going to result in improved outcomes. So when people do come to me for preconception visits, I often send them home on birth control with a plan to come back in 3 months or 6 months after weight reduction. But when people come to us in pregnancy, it's too late to make those types of recommendations. Preconception counseling is critical, as I've mentioned. It also lets us screen patients for associated subclinical disease. Hypertension over time can affect someone's heart and kidneys, and we screen for those subclinical disease before pregnancy. And then it allows us to give patients information about risk stratification. If they have pre-existing renal disease or heart disease, their risk in pregnancy are going to be greater. And if they come in a preconception context, we can talk with patients and manage their expectations. And then patients can choose if they want to pursue a pregnancy or if they would consider family building through other means like adoption or surrogacy that would not expose that patient to the risks. Preconception counseling also allows us to do, antihypertensive care and management before pregnancy starts. So if someone is on a blood pressure medication that's not safe for pregnancy, like an ACE inhibitor, which is associated with birth defects, we can switch patients to safe alternative blood pressure medications and give them time to then optimize their blood pressures so that when they go into pregnancy, they're on safe and stable medications and that their blood pressures are optimally controlled. So current care in chronic hypertension, it's focused on the management of the disease during pregnancy, which I'll talk about next. But what we need is more people coming in for preconception visits so that we can optimize their care before they get pregnant. So this is a checklist I pulled from a nice review on chronic hypertension that outlines what we do in pregnancy for our patients with chronic hypertension. It focuses on low-dose aspirin as a strategy to reduce the risk of preeclampsia. We know that aspirin, when started at 12 weeks, can decrease the risk of preeclampsia, of growth restriction, and need to deliver a patient early for these complications. We do early recognition of complications for patients who have chronic hypertension with surveillance of fetal growth and well-being, and then time delivery based on blood pressure control and other complications. So optimally, we are delivering these patients before complications occur. And finally, critical to the management of chronic hypertension is good postpartum management and evaluation of blood pressures, where we check pressures for people who have preeclampsia and people who have chronic hypertension, the 3 days after they deliver, but also 7 to 10 days after delivery. So in the case that someone has postpartum hypertension, it's recognized and interventions are enacted before injury or complications occur. So that's the mainstay of treatment right now in pregnancy. If we can get them into for preconception counseling, we can make a big difference. And if we, otherwise it's during pregnancy, it's starting aspirin, it's monitoring for complications and delivery before complications occur with good postpartum follow-up. There's a really important and interesting question is, should we be more aggressive about treating chronic hypertension in pregnancy? The 2017 ACC/AHA guidelines that changed the definition of hypertension for non-pregnant adults also recommended antihypertensive therapy for adults who have stage 1 hypertension and who have or at increased risk for cardiovascular disease based on an atherosclerotic cardiovascular disease risk score. So they're recommending treatment at blood pressures that we would typically not use blood pressure meds in pregnancy. And the reason for that is because when we administer antihypertensive medications to a pregnant person, we decrease that person's blood pressures, and that may decrease perfusion to a fetus, and that has the potential to impact growth of a baby and even lead to growth restriction. So we shouldn't extrapolate this recommendation to pregnant people. But the question is, if we are more aggressive about treating people who have mild hypertension in pregnancy, can we reduce the risk of preeclampsia? Understanding there may be a risk of growth impairment. And so this has been studied in small studies. We need bigger studies. And this table summarizes a Cochrane review that looked at antihypertensive therapy for people who have mild chronic hypertension. And it looked at people who received treatment for mild chronic hypertension with blood pressure medications or placebo. And what they saw is that in women who had mild hypertension, who were treated with antihypertensive medications, there was a significant reduction in the development of severe hypertension in pregnancy by about 50%. And we, of course, were worried, could this be at the expense of higher rates of complications like growth restriction or perinatal death? And the data from this Cochrane review was favorable and suggested there wasn't an increase in fetal death and neonatal death, and there wasn't an increase in small for gestational age or preterm births for patients who had mild chronic hypertension who were treated with blood pressure meds, again, at a time when we would typically not use blood pressure meds in pregnancy. The American College of Obstetricians and Gynecologists has said we should use blood pressure meds for chronic hypertensives when the blood pressure is above 160/110. This is a recommendation that is older, but it's still affirmed by ACOG, and they say in their bulletin that they're not going to change these recommendations until there's newer randomized clinical trials that are appropriately powered and suggest the real benefit. And I will tell you that we just participated in a very large trial called the Chronic Hypertension and Pregnancy Trial, or the CHAP trial. It had 72 centers across the United States, and it was just this trial. It was a pragmatic, randomized trial, and the aim was to evaluate the benefits and harms of blood pressure medications for mild chronic hypertension. Women were randomized to routine care versus treatment with labetalol or nifedipine for mild chronic hypertension. And this study recently finished recruitment and understand is being analyzed, and the paper's being written, and I'm hopeful that it's going to provide insight so that maybe this will be an approach that will allow us to be more aggressive about treatment of of chronic hypertension in pregnancy, and maybe reduce some of the risks that come with this disease. There are other things that we also need to do. We need, I think, innovative steps if we're going to impact chronic hypertension risks. There's promising research exploring serum biomarkers, mean arterial pressure monitoring, and ultrasound in the first trimester to identify patients who are at risk for preeclampsia and other complications. And there's a lot more to come, I think, in this area. And also, there's actually some really interesting and compelling research looking at pravastatin, which is a medicine to lower blood pressure, blood cholesterols. And it also has some interesting anti-angiogenic effects. And in studies where women with preterm preeclampsia received this medication, we saw improvement in blood pressure, reduction in S-FLIT serum concentrations, and improved pregnancy outcomes. And then there was a small study that recently was published in the American Journal of Obstetrics and Gynecology. It was a RCT. It was a multi-center, double-blind, placebo control of pravastatin versus placebo for singletons who were at increased risk for preeclampsia. And this medication was associated with a significant reduction in preeclampsia and rates of preterm birth. So I think it's innovations like this, which are innovative and novel, that we need to explore if we're really hoping to make a difference in chronic hypertension and reduce those adverse outcomes. And this is a challenging comment here, and one that requires a lot more attention because there are so many challenges that remain to understanding and overcoming ethnic and racial disparities in the prevalence and treatment and outcomes of chronic hypertension in pregnancy. We need to acknowledge and address the key role of social determinants of health in these outcomes, including educational status, access to care, and low income. We need to implement healthcare policies at the national and state level to reduce these disparities. And finally, while the genetic and environmental factors that contribute to these disparities are not well understood, we need more research there. But the development of cardiovascular disease risk tools for minorities and the evolution of precision medicine may help optimize hypertension management in pregnancy. We need to work on this especially. And I think many people heard about this very sad story in sort of November of 2020. A young Black woman, actually a pediatrics resident, she was a physician, who died after her giving birth to her baby from complications of preeclampsia. And this very sad case received national attention because it really underscores the importance of combating these disparities in care related to hypertension in this country. So here are some of my concluding points. We have seen a significant increase in the rates of chronic hypertension in the last 4 decades in the United States. We've seen MMRs associated with chronic hypertension that have increased, while MMRs associated with preeclampsia have declined. So we're doing better with preeclampsia. We need to focus on chronic hypertension. And during all of this, these trends have shown a persistent 3 to 4-fold higher rates of adverse outcomes and notably hypertension-associated maternal mortality for Black women compared to white women. So we need to find and overcome the challenges that have led to ethnic and racial disparities. And it's time to focus on innovative management of chronic hypertension. I think that's should be one of our next areas for challenge and for research moving forward. So I want to thank everyone for participating and attending today's lecture, and I'm happy to answer any questions.
Thank you, Dr. Bryant, for such a wonderful presentation. So we do have a few questions here for you. Okay. Do you receive referrals from the FQHCs, and is this covered under insurance for Medicaid?
Yeah, so I assume this question is related to preconception counseling, and we do. Here at Rutgers, we have a Medicaid clinic associated with our department, with our hospital, excuse me. We also see patients in our faculty practice, but these preconception visits are covered and should be encouraged. And it's such a critical step for us to optimize someone's condition in medical disease before pregnancy. It represents the preconception visit fewer than 5% of all visits that I do. And that small percentage of visits it represents visits where I can make much bigger impact than if people just come to me when they're already pregnant and on meds that are unsafe, or their blood pressures are out of control, or they have unrecognized heart disease or renal disease associated with longstanding hypertension.
Thank you. If a patient is allergic to aspirin, is there another medication that they can take?
We use baby aspirin as a strategy to reduce the risk of preeclampsia. That benefit is small, but it is significant. So if patients have an allergy to aspirin, we probably wouldn't use it. There's some emerging evidence that metformin may be an alternative that can decrease the risk of preeclampsia. It's probably most effective in women who are obese, but there isn't yet high quality data that would make us, that would inform a recommendation that all people should be on metformin as a strategy to reduce the risk of preeclampsia. So at this time, if someone has an allergy to aspirin, we would just not use that to decrease the risk of preeclampsia.
Okay, great, thank you. This is just a message that someone wanted to share. Is racial stresses taken into consideration for your patients from minority backgrounds, less of social determinants, but looking at their day-to-day stresses and living in a racialized society, like not putting all of the blame on the patient? As a Black woman with a thicker body, I often have to fight stereotypes from doctors and medical staff, especially at OBGYN offices, just hoping that this is taken into consideration. People from different cultural backgrounds deal with different stresses on a daily basis, regardless of class and economic status.
Thank you for that comment. The blame does not belong on any patient here. It belongs on the system that limits access to care and makes patients feel stress. I mean, there's so much we can do to improve the situation for people of diverse ethnic and racial groups. And I appreciate the comment, because we need to do better so that no person of different race or gender or anything should feel pressure or stress because of the barriers that we put forth in the healthcare system.
Absolutely. What is the advice for immediate postpartum monitoring? Are the maternal mortalities happening before, during, or after delivery?
Yeah, it's a good question. During and after delivery, the most important thing we can do is monitor blood pressures and respond to hypertensive urgency. In the hospital setting, we have medications that can lower blood pressure. We have magnesium to decrease the risk of seizure. We're good, I think, in the hospital setting most of the time. I mean, certainly we see bad outcomes, in some cases, but that's the time when we're in a monitored setting, when we have the ability to act and respond quickly. It's the postpartum period when people have complications like seizures or hypertensive urgency at home, when people can get really sick, I think, and often, will die or suffer a serious injury. So first of all, we need to counsel people about the signs and symptoms of preeclampsia. So people are looking out for, a headache that doesn't go away with Tylenol, or changes in their vision, or pain on the right side over their liver. Patients need to leave the hospital fully aware of those symptoms and have a low threshold to call. The blood pressures after delivery may be okay, but they do tend to increase on the second or third day after a delivery, especially one that's complicated by preeclampsia. The blood volume is expanded, and a pregnant person mobilizes that fluid after delivery. It goes into the bloodstream, and they have to sort of urinate that extra fluid out. And that's a time when often we'll see blood pressures go up. But many people go home on the second day after a natural delivery. So we need to actually encourage patients who have preeclampsia or gestational hypertension or chronic hypertension to check their blood pressures at home. And I think we need more accessible and cheap blood pressure cuffs so that patients know to check it and that they can check it and that they know when to call. When that blood pressure is in the severe range, 160 over 110, they call, they come in, and then they get checked out. So on that third day, every patient needs a blood pressure check. And then in the first week after a pregnancy complicated by, again, chronic hypertension or preeclampsia, 7 to 10 days after delivery, patients should be seen in the office for a check up for blood pressure evaluation and screening for symptoms of preeclampsia. If we can do these things more effectively, we can identify patients who are hypertensive and who are at risk for complications, and we can start medications. In some cases, we start magnesium and admit patients to the hospital to decrease the risk of seizures. But what happens often is patients deliver and then we don't see them again, and then we see bad outcomes. And there's actually some neat and emerging research using text-based systems where we can text electronically. Patients will receive a text message saying, hey, it's your third day after your delivery, check your blood pressure, and if it's high, call us. And that's actually been shown to be effective in groups of minority people, better than asking them to come in for a postpartum blood pressure check.
Great, thank you so much for that feedback. Okay, how do you see the role of primary care in preconception counseling, or do you think preconception counseling should be the exclusive role of MFM clinics?
That's a great question, and I appreciate that. No, I think primary care needs to focus on pregnancy and future reproductive goals. We don't, I think, realize that obesity is such a significant contribution for adverse outcomes in pregnancy. So if someone's obese, I mean, it's a hard thing to get people to lose weight and to become healthier, but maybe they should know that pregnancy in the near future should be maybe thought of as relatively contraindicated, and that patient should be on birth control until they're working towards a better weight. So I think the primary care setting needs to focus on future reproductive goals, and patients need to know that things like obesity, high blood pressure, and aging are things that are risk factors for complications in pregnancy. So definitely it should take place in the primary care setting, and I hope everyone's thinking about it.
Great, thank you. In the absence of medication for pregnant women with HTN, what do you consider as key recommendation in treating OBGYN NPs to follow? Also, what would you encourage women to do to advocate for themselves?
Could you read that first part of the question one more time?
In the absence of medication for pregnant women with HTN, what do you consider as key recommendation in treating OBGYN and NPs?
So one of the things we want women to do and pregnant people to do is just come into pregnancy as healthy as possible. And in the first trimester, the blood pressures often drop for everyone physiologically. And so some people, if they come in with good blood pressures, their blood pressures may drop. They may not need to be on a blood pressure medication during pregnancy. So coming into pregnancy with optimized blood pressure is really very important. Avoiding excessive weight gain, avoiding diets that are very rich and heavy in sodium may also help. Historically, people thought of pregnancy as a time when they're not very active, and there's a lot of just like bed rest, things like that. Well, that's kind of old-fashioned thinking now, and we want to encourage patients to be active, to exercise, even during pregnancy. So these healthy lifestyle choices, avoiding excessive weight gain as well, can absolutely be non-pharmacologic ways to keep blood pressures down and safe during pregnancy.
Great, thank you. When you recommend changes to diet, exercise, lifestyle prior to pregnancy, what is the success rate for healthy outcomes? Are members compliant with the treatment plan prior to conceiving?
So it's challenging for me in a preconception setting because I understand that a patient in front of me has family planning goals and family planning desires. And so when I tell somebody who's generally healthy but is obese, that they should not get pregnant, they say, that's not a recommendation I can comply with, and they just get pregnant. But especially when someone's BMI is over 40, that's when we know the complications associated with obesity are greatest in pregnancy. So, it's so individual, the success rates, and some people are motivated, some people are less motivated, and it's also incorporates people's family planning needs and desires. So I really can't tell someone at age 40, they need to, take 6 months and lose weight, whereas that conversation is much easier to have with someone who's 25. So it's a hard question to answer, but we want people to recognize that obesity is modifiable, and in some cases, and it's something that is associated with adverse pregnancy outcomes. It requires a lot of effort, but if we can make strides in lowering weight so that people come into pregnancy with a normal BMI, they're going to do better and have less hypertensive complications in pregnancy.
Okay, and I have one more question here for you. How much do you see improvements in preeclampsia outcome as OBGYNs taking ownership of disease diagnosis and management? Whereas chronic hypertension is not a disease exclusively of pregnancy, and therefore the management may not be owned by the OBGYN during pregnancy.
I think there's some truth to that question, and I think we have focused on preeclampsia and hypertensive urgency associated with preeclampsia and all those bundles that are available. They're a reaction to hypertension that we as OB and MFMs have implemented. And when people have chronic hypertension, they come into pregnancy, it's different. They come in with high blood pressures, and now we're responding in a different way. So if patients can come into pregnancy with their blood pressures optimized and maybe not on medications, it's going to be a different situation. So I do agree. I think that we have historically focused a lot on preeclampsia, and it is a dangerous disease, and that is why. And now it's time for us to work on these modifiable risk factors in the preconception setting, and maybe these novel innovations during pregnancy that can reduce some of the complications that come with chronic hypertension.
Thank you so much, Dr. Brandt. I do want to respect your time. This was a really great and informative presentation. As mentioned, everyone, this webinar would be uploaded to our YouTube channel at the end of the week. Thank you again, and please stay tuned for our April webinar. And I hope you all have a great day. Thank you again, Dr. Brandt.
Thank you.
Okay, thank you. Take care, everyone.